Welcome to our board meeting, and where's Audiana? Oh, yeah, Audiana, I just want to say thanks for prompting me to come up and use a decent sized screen. It certainly makes it a heck of a lot easier. Brilliant. Look, we'll open with our karakia. Kia hora te marino, ki whakapapa panamu te moana, I horahi mā tātou I te rangi nei, araha atu, araha mai, tātou I tātou ina wā katoa, hui e taihiki e. The only apology that we've got is Norman.
That's right, and everybody else is on the call, Brendan.
Brilliant, thank you. I'm not aware of any late items. And on our register of interest, if we've got any particular points that we need to identify, Jenny?
Yes, just to notify that I have let Margaret know to remove my interest, or that I'm no longer have an interest in Bernardo's Bumps to Babies, Parent Centre Parenting Education, or the locality group for the primary maternity project. I do, however, wish to note an interest through contracting I'm doing for HLC Life to the Max.
Perfect. Okay, thank you for that. I'm sorry, Karen.
Thanks, Brendan. Just to note a potential conflict, or not conflict, overlap with the midwifery workforce update today under the section of 3.2. It refers to changes in the gynae assessment unit, which is the direct area that I work as a staff nurse. So I just thought I would identify that. There's no decision, but I just thought I'd make it clear that that's my area of work.
Sure. Okay. Thank you. Rightio. So we've got the minutes of the meeting of the 28th of September. Is somebody prepared to move receipt of those minutes? So move John, seconded Vaughan. Is there any discussion on those minutes? There's no discussion. We can move then to the next item on the agenda, which is the verbal report from the chair.
Sorry, Brendan, I thought you were moving to matters arising.
Oh, sorry, are there any?
Just on the matters arising schedule, I just had a question related to the review of car parking arrangements. It says after traffic engineering review completed, and I'm just wondering what the timing of that is, because this has been on the schedule for such a long time and obviously quite an ongoing issue. So just wondering when that feedback, or when that paper will come back to the board.
Neil?
Yeah, I'm happy to speak to that. The traffic engineering review is actually a long-term piece of work. We're recognising that there are a significant number of major changes to the site. There are changes we probably need to relate into that in terms of some of the technologies that we deploy to, for instance, barrier arms and so forth. And so that will be a piece of work that is not this year.
So when it says scheduled, status is scheduled, when is that scheduled for in terms of the report back to the board?
Sorry, I don't have that in my head. I can't answer that question in a minute. I can get that for you.
Yeah, thank you.
Okay, any other points and matters arising? Rightio, so we've got the verbal update from the board chair. So just for formality, we've had our board only session this morning with some topics that I'll pick up and obviously respond to. The main topic clearly is COVID, and I just want to put a shout out to the team for what I have to say is it's an extraordinary effort to get to 90%. And every day I go online and I look at the reducing number of targets that we get that we're aiming for, and I think this morning it's 3,642 or a number pretty close to that. And every DHB in the country has clearly set its targets and its objectives. And Deb, you're there, and I know, I mean, you're not the only one I know, but I do want to say that I caught up to your office, I can't remember, it was last week or the week before, and look, I have to say that on behalf of the board, it is an extraordinary effort that is occurring at the moment. And I don't think any board member could disagree with that. In terms of trying to get to that final number, we know there's massive challenges around that. And whoever we are, wherever we are within the rohi that we're responsible for, I think we all as board members are advocating in the most positive and affirming way. I just wish we could get to the number tomorrow, and I think it's a terrifying number to still nail when you look at how many we do each day. And I just want to relate two stories from a chair's perspective. So this is not a highfalutin report, but I did drop into Shannon a couple of weeks ago and found 5 people on the side of the road with the bus set up and a couple of flags flying, and virtually nobody wanting to get vaccinated. That team walked the length of Shannon, walked into every shop, and I have to say, got a less than receptive response in that community. And I think that highlighted the magnitude of the challenge. I mean, it's all right turning up, but it's the discussions and those additional levels of energy that have to go into trying to get these people across the line. The highlight of the story was a gentleman came up for his first vaccination. He understood he had to wait 15 minutes afterwards and wanted to know where could they hide him so nobody else in the street could see him. And I suppose that again gives you that sense of what this is about. It's not just charging around the district jabbing people, it's all those other challenges. He wanted to get it, but he didn't want his family to see him get it. So I highlight that story last week to my horror, but to my wife's delight. I went to that shopping mall in Palmerston North, that big shopping centre, which is probably about 5 years since I was last there. And here's our team in there. And I spoke to them at midday, and the lady that I spoke to had a little piece of paper, and she was ticking off 5 at a time how many they vaccinated, and again had a little separate sheet of the number of first time. And she was saying that it's being respectful to them and sitting and talking and just helping them through the process. So I suppose, here we are charging around jab, but what we need to understand is there's a massive amount of additional background work that goes on. Oriana Matharo, you know better than I what's going on in iwi space. You know far better than I the depth of the challenges that we've got there. And all I have to say to everybody is that we as a DHB set a target at the start of this process, and we're stuck to budget effectively, Kelvin. We've kept to the line, we've kept to the target, and my understanding is that by the 10th of December, we should be at that 90. Well, that's the date I've set. I think you guys set the 8th, but I rolled it out for the Friday because it felt better. So look, I'm not going to go into detail about other stuff because I think this is the highest point of interest at the moment for me, is getting to that 90%. So I just want to say on behalf of the board, to Kath, your team, thanks for the effort and the energy. Very few of us appreciate it. I will finish off. Oriana, you and Kelvin were over, I think, Pahi tour last week, deep in the night.
Danny Berg,
speaking to very small numbers of people in a deeply respectful, calm and measured way. And those are the actions that make a difference. It might only be 10 people there, but they might be 10 people from 10 different whānau. Who knows? So that number multiplies out. So that's it from me from a board chair's perspective. Where's Oriana? God, the screen's great.
Here I am.
There you are, you're over there. I found you. Do you want an update on FRAC, Oriana?
On FRAC, I'll just quickly make a comment about the COVID effort, and it's everything that you've said, and I'm speaking from a iwi Māori perspective. It's everything that you said, Brendan, times about 100 in terms of the efforts, the conversations, the ways of communicating and cooperating with others to get people over the line. And if we use the Danny Burke example, So Calvin and I have been in contact for a fortnight before that, and in contact with the Dennywork whānau, trying to find a time and a space that was suitable for them. And you are right, small numbers, but exponentially, if we could have got at least 2 of those people over the line, that will have a multiplier effect in terms of their whānau getting over the line as well. So, it might seem like a small effort front facing, but there's lots of reward if we take the time. Same for Shannon. We know that Shannon needs a lot of support. So it's not just about, having a pop-up there, it's about all the conversations and the discussion prior to get people to go to the pop-up or to the RV or to the site or wherever, and so there's a lot of work going on in the background to make sure that that we do that. Very big whānau down there that are not vaccinating, so if we can put it bluntly, turn one person a champion in that whānau, we know that person will bring the rest of them along. So yep, great efforts, and grateful for the support we get from the DHB and from our wider whānau in the community as well. And in terms of FRAC, no, and we're going to talk about it a bit more as we go along, but really pleased that we were able to make the considered decisions that we did on the day in terms of supporting the spend and the things that we're spending funding on, but other than that, no further comment.
Do you want to just clean up on the mana whenua holder? Any commentary?
Is that?
I'll move the minutes of the FRAC though, Brendan, before you want to move on.
Oh, rightio. Okay.
I'll move the minutes.
Oh, brilliant. Thank you.
I'll second.
And seconded by Oriana. Thank you. In favour, please say aye. Against, carried. Brilliant. Rightio. So, have we got any commentary on the mana whenua holder report?
I mean, some of that we're going to talk about this afternoon in the chair to chair. Yeah. And so whether people want to just leave it for that, unless anyone's got any questions in terms of our board, or Tracy may have something that you'd like to add.
No, I'm happy with the way that the report is written. Thanks, Oriana.
Yeah, so given that we have got the discussion this afternoon, are we all comfortable to move the resolution? Prepared to move, Oriana, and seconded by Heather. In favour, please say aye. Against, it's carried. Fantastic. Okay, so we're moving now to the CE's report.
Thanks, Brendan.
Welcome, Kath.
Thank you. There are a range of items that the board has been updated on. What I might just do is take a moment to talk about something that's sort of front of mind for us at the moment, which is the Vaccination Order, which comes into effect at 11:59 on the 15th of November. So that's one of the big efforts that we have in place at the moment, having conversations with our staff, ensuring that we're aware of all of the vaccination status of all of our staff, which is cross-checking with the CIR, where all of the COVID immunisations are stored. At this stage, we've got some unknown vaccination status, of staff. So we're following up with those individual staff members, but we still also have staff members who have clearly articulated that they will not be being immunised. So there's quite a strong national process that has been put in place to ensure there's national consistency in the way DHBs approach that. To cut a long story short, people will be stood down if they've indicated that they are not prepared to be immunised, which ultimately will probably lead to those individuals being removed from their roles in the organisation. But be fair to say that we're doing everything that we can to encourage, support, answer questions, communicate. Calvin's had a number of sessions. We've got other staff members who've identified that they're available to talk to people. So that's just a work in progress for us.
Okay, there's a couple of questions, Lou and Vaughan and Karen. Lou?
Off
You need
mute.
to put your do for thing.
Do we know how many of our staff have not been double vaxxed?
We're well, in terms of the immunisation status, although we've just got to follow up, and where we're following up with the staff members that we're not knowing, they probably are, but we've got issues where people might have changed names, you know, for example, got married or what have you, and that's where we're just checking that against the CIR. But we're well into the 90, more than 95%, Lou. I think that's of the first. Where's Calvin? I can't see you. Can you recall the number yesterday?
I think Kaya mentioned very close, well, certainly for the medical side, it's very close to 97%. But as Kath has pointed out, there are a few people who haven't responded. There's some people have been on bereavement leave, personal circumstances that they haven't been on site, and we just haven't been able to get that information. I think maybe Gabriel could also just mention from Allied Health perspective, there will be a few crux areas, and we're just trying to look and understand, mitigate what some of those impacts will be within the organisation if the non-vaccinated status is taken to the nth degree. I would just point out that the vaccination centres and the work that Bronwyn Warren has done, they are actually keeping some of the vaccination centres right open till 11:59 before the deadline sort of kicks in order to create every opportunity for any staff member to be vaccinated prior to that time.
The reason I'm concerned, if we have 3 to 5% of our staff that have to leave, we already have a shortage of staff in most areas. How's that going to affect us?
So we think it's going to be a low number of staff ultimately, Lou. We've got another week to work through that. You know, we're just working with those individuals. At this stage, there's, whilst, you know, no staff member choosing to resign, which some staff members are, or, you know, or leaving is what we want, but we think that we will be able to manage forward.
Okay, so we've got Vaughan and Mataroa, and then I'm going to pick up a question from, I think it was Oriana. So Karen. So Vaughan, Mataroa, Karen, Oriana.
Thank you, Brendan. My question was again on the ones that have declared that they won't take the vaccine, and I understood at FRAC that number was 49 known, and there's still a portion of unknown. So my question is if we've got any update from that number, and what is the plan around the care capacity on each ward or for staff rostering? And even again, I understood that some of those roles were clerical. What's the training program and recruitment to cover those gaps in the meantime? Because there's going to be a month of added stress at least leading into Christmas where those staff vacancies are going to play out. So
those numbers have dropped considerably since we reported to FRAC, Vaughan, and I'm sort of loath to give a specific number because they're dropping every day, and we're confident that we are not going to be in a position that this causes significant difficulty. Probably, and I'm very mindful, I don't want to be more explicit in this environment because small numbers, and I could inadvertently identify individual staff members to you in this forum, which is probably not the right thing to do.
Okay. Thank you.
Mataroa.
Morena, my question probably was in line with Vaughan's, wanting to understand the actual numbers and therefore the impact. Even one person is quite traumatic for an organisation. And you know, it's a big issue in education. I heard this morning country school out of Taumaranui, 7 staff, no one vaccinated, not necessarily intending to get vaccinated. It's a whole school gone. So there are some bigger issues at play here, because that will have other impacts on health. You know, if people are resigning, they don't have a job, their household income drops. So it is a bigger context to also be thinking about that.
Yeah, I also saw that same interview. The principal said that she hadn't had time to get vaccinated. So for us staying open until 11:59 is good. So giving them a chance. Karen?
Yeah, thanks, Brendan. Look, my question was very similar to the others around the numbers. The report on page 6 said that the number was down to 41 that hadn't been vaccinated as of the 2nd of November. So, I mean, I guess that I worked that out, if we've got 2,700 staff, to be about 1.5%. So I don't know. I acknowledge the concerns around I wouldn't expect to be identifying staff members, but I think seeing that number come down, it would be interesting to know what it is now and how much it will come down. I hope it comes right down. But I mean, to think of it as 1.5%, that seems, if we are at 98.5%, that is still quite a bit more than the 95 or 90. What's been indicated. So I hear there's a hesitancy to acknowledge the numbers, but that I guess it being in our report, it would be good to sort of see that track down.
I think my hesitancy is that it changes every day.
Yeah.
That's the only thing. And so the critical number will be when we get to the 15th. And you know, if the board would appreciate it, I think what it might be quite good is if we can shoot out a note to you on the 15th and say, right, we're about to go into midnight tonight. This is exactly the situation, and this is where this is what we're doing about it. But I would say that there are, at this stage, yes, there are some roles that we are concerned about, but the team assures me this is not going to cause any business interruption at all.
And just further to that, I heard the Prime Minister kind of rolling out the 4-week notice period that people would be given if they were unvaccinated. Is that the same in health? So would there be that extra 4 weeks that people could act, or is it actually that if they haven't got it by the 15th, they're out?
They have to be out of the business, but they could be on leave without pay or on annual leave.
Okay.
And then they have an option to choose to still be immunised within that notice period. Yeah, so that will depend on people's individual contract or MECA arrangements in terms of notice periods.
Okay, thank you.
Miriam?
Thank you, and thank you for that discussion, Kath, around COVID. Mine is also on COVID, so I'm sorry to carry it on a bit longer. I know there's other things to talk about, but I was reflecting, I think last night when I heard about the fact that boosters have now been approved for the wider population, and it may well not be that long before the vaccine's approved for children over 5. And I think one of the things that as a board we need to keep in mind is this isn't like getting to the target, isn't the end of this massive campaign and huge amount of work that everybody's doing, but the ongoing, possibly long-term impact of this. And I think just as a board, we need to reflect on that and think about what support, what other support we can give, what acknowledgements are required, because it's not just right, we've met the target, now we can go home and have a rest. And some of the staff, probably most of the staff involved in the campaign, have been doing this non-stop for months and months and months. So I just really wanted to make that comment.
Yeah, if I could respond, which is a conversation I guess I was having with one of the mayors yesterday, is that whilst there's a 90% target for our rohi, we would like every individual to choose to have a vaccination. and we will continue to be encouraging and supporting that. And Deb is living and breathing every day, not only the expectation about COVID immunisation, but as we move forward, the Ministry has been very clear that we need to also maintain our focus on measles and childhood immunisation. So I think the broader immunisation program is probably moving into a slightly different phase as we get closer to having the majority of this population vaccinated. We certainly won't be putting our feet up. There's a lot of work to do in the broader immunisation programs.
Okay, just checking, Oriana, you fired a question. I don't know how to do this messaging thing.
Oh, okay. So the question I asked is, do we have an idea around our unvaccinated status across the sector? So, aged care, our contracted providers.
Okay, Keith.
Not only our DHB, MidCentral Health, Kaimahi, but right across the sector.
Absolutely, and part of the national conversation around timing has taken into account some of those different sectors and the time that they require, such as the home and community support sector. We're having regular conversations with providers, but there's still some ongoing work around, how those things will be monitored and who has responsibility and accountability. And I guess the one that you've just put up is a really good one, Vaughan, in terms of getting clarity around the lead maternity carers who are contracted to the Ministry. But of course, coming into our hospital, we're asking the question because we need to know that status.
Okay, Kath, so we're still on your report. You happy to keep?
Yeah, I'll take any questions that anybody has of the rest of the report. I guess the one thing I will do, if I can, is just acknowledge, because I think Kelly, I saw Kelly on here, but maybe she's
still there.
She's still there? I can't see. Oh, there you are, Kelly, over there. Sorry, I've got all these little glasses. I just want to acknowledge that this is Kelly's final day after 7 years at the DHB, who will be taking up a role at Think Kaora. So Kelly will be missed by us all. She's been a fabulous contributor to the DHB, and she'll be a fabulous contributor to the system, I guess, and the sector as a whole, in her role at Think Kaora as well.
So just while we're still on the CE report, the inaugural Golden HIP Awards, where we are the 3rd best hospital in the country. Hip, hip, hooray.
Yeah.
And do you want to make any comment in the financial update 2.5 on your report, or do you want to leave that until we get through to Neil?
Well, we'll have the actual financials reported later on. We now have the October result, and hip hip hooray, another one. We actually did manage to do slightly better than budget. So that's been a bit of a challenge to get, for the first couple of months, but, we're hopeful that we'll get things back on track. We'll be starting to forecast now that we've had the first quarter, we'll be starting to forecast the end year position. So I guess I'll say that that'll be coming in your weekly update at the end of the week, but good. In fact, the weekly update, I might use that to give you a bit of an update on the vaccination as well. So given Friday's, Monday's not much change. So yeah, so all good.
Okay, last question, I think, Vaughan, and then we'll go to the resolution.
Thank you, Chair. Just really about, not so much a question, just wanted to acknowledge the commencement of Spire with the construction. I think it's a milestone moment, and really want to just make an acknowledgement on that. Thank you.
Brilliant, brilliant. And on that basis, you're moving the recommendation to note the update.
Happy, thank you.
Okay, so moved, Vaughan, seconded, Muriel. Put that in favour, aye, against, carried. So brilliant, thank you. So we're moving to the board KPI dashboard 4.2. Kelly?
Yes.
Kelly in the shade, there you are.
Here I am.
Take full charge, Kelly.
Fantastic. Kia ora, everyone. So the KPI dashboard. So immunisation rates, so obviously you have discussed a lot about COVID today, but as Kath quite rightly noted, the immunisation overall is really important and has been fundamentally impacted by obviously COVID. So there's a concerted effort in regards to ensuring that there's actually multiple plans in place across all localities to maintain immunisations and improve immunisation rates. There is a particular focus, as you can see in the report, on horowhenua, because that is an area of particular challenge and concern. So that's great to have that focus there. Obviously, we've been working on the 12 health system indicators in regards to the KPI dashboard report. So that will be reflective of the 12 health system indicators as of the February report, because the data has been a bit slow in coming in from the ministry and has only just been put in place. So what will happen with the KPI dashboard report in February will be that there'll be a tile, the same as the one that you currently have, but it'll be just one page with the 12 health system indicators. We won't lose any information, because the information that currently is in this report is also in the non-financial report. So it actually reduces duplication of reporting and will succinctly present a much easier to read dashboard with key information focused on those 12 system indicators is the idea. Happy to take any other questions.
Brilliant, Kelly. Jenny, and then Karen.
Kia ora, thank you, Kelly, for your report. So yes, I am going to pick the part that you've highlighted to around horowhenua and the, that you link to immunisation rates. It's a topic I feel like I frequently bring up, is that ability to enrol a newborn with GP, which previously, whilst there's been a challenge in this area to enrol with a general practice, they've at least taken newborns. Each meeting I seek reassurance, and now to see that it's actually even worse, because to my knowledge, this is the first time they're not even taking newborns. I'm incredibly...
Yeah,
it's an incredible concern, and we can say we're focusing on horowhenua, but what actually are we doing differently? Because how I read it, that is worse in terms of service provision. That's worse. We know we have a high Māori population in horowhenua. We also know, and it's worded in the report, that for one quarter they were not enrolling. So I don't know if that's now changed suddenly this quarter. But in saying that, the legacy of not enrolling, that goes well beyond the time period of why they're not taking enrolments. That's word on the street, and people simply then give up and don't try anymore. So yes, it affects immunisation rates, but actually this is going to affect the well-being of our babies. And we have a project going on called the First 1,000 Days. Yes. I couldn't express my level of concern enough, and when we're reading that.
Absolutely. I don't know if Deb's on there and wants to talk to that at all.
Where is Deb? Hello, Deb. No, can't see it. We're going to need to, so we mustn't lose this discussion. So Kathy, at some point you might need to chime in, but we're just here from Mataroa. It's on the same line, Mataroa.
Deb's just about to restart because her Zoom connection dropped out. So can I just, when she comes back on, she's all over this and she's meeting weekly with Chiquita about these issues. In fact, that's probably her now. Here she is. So, Deb, sorry that you dropped out, and I'm not sure how much. Not sure how much. Okay.
I had a complete meltdown. I had to restart.
Sorry.
Okay, so just for clarity, so Jenny, you articulate it back to Deb, and then Mataroa will go to you after that. Yeah.
I'll try and do my impassioned cry for help more succinct. Deb, just incredibly concerned that we're not now enrolling newborns even in horowhenua. So we've had the enrolment issue for a long time. I continually hear at meetings, we're working on that now to see we're not even taking newborns. Concerned, yes, about vaccination rates, but concerned about the impact on the wellbeing of that you know, for our babies in the first 1,000 days and you know, the lifelong impacts then of that in general. So I guess I'm seeking a reassurance. What are we doing differently? Because actually what I'm reading is our situation's now worse within general practice if we're not even taking these newborns who need to be back, who need to receive their 6-week vaccinations at general practice, right?
Yes, yep. Absolutely, like you, we are concerned. The only development I can report since this report was developed and will be in the refreshed HDAT report is that with the opening of Kamiora, the nurse practitioner-led practice downtown, is the commitment that we'll be able to enrol up to 850 people there. They have transferred some people across, but their focus is absolutely on Mama Pepe, Tamariki and Māori. And we're seeking a much clearer update for HDAT for the next meeting in terms of, you know, what the next tactics are.
Is that effective immediately? Because that practice is up and running, like you say. So it said they weren't enrolling for that quarter. So newborns can now be enrolled.
Yeah, I understand they're prioritising newborns, Tamariki, Mama Pepe, Māori.
So Deb, I was also saying that, and so I don't know if some socialisation of that message is going to be put out in the Horowhenua community, because what absolutely happens is as soon as the number of people try and enrol, so it happened in the adult population, now if it's happening in babies, they're trying to enrol their babies, they're not enrolling babies, that message goes out and we're going to miss a whole nother cohort, even if they now can enrol that baby. So I'm wondering if there is going to be some promotion around that practice and the ability to enrol that priority group in particular.
Yep, so that was a specific aspect that we discussed with Chiquita late last week in terms of what is the communication engagement. So they're trying to balance being a sort of a broadcasted message versus a specific message around the target population. So if you've got any advice about how we can support that in the Horowhenua, that'd be fantastic. Thanks, Jenny.
Okay, Mataroa.
Thank you, Brendan. Morena Kelly.
Morena.
Congratulations on your new role.
Thank you.
Yeah, and thank you for your work. I just wanted to check in about a couple of things. So the new sort of system level measures, the new refreshed look with the tile, does that mean then, because this report also has a focus on Māori, non-Māori inequity?
Yes.
And in the table where it describes what the new measures will be, I don't see any information that tells me it'll still continue to have a focus on equity and specifically non-Māori and Māori data. So I was wondering about that because I do see, like, take for instance on page 10, the outpatient appointments, Māori, non-contact outpatient appointments, non-Māori. Like, when you look at that and the numbers, there's significant difference, and I can't tell whether or not so proportionate to the Māori population and the rate of referrals to outpatients for these non-contact appointments, are we actually meeting equity for the Māori population? I can't tell the answer to that from that graph.
Sure, absolutely hear what you're saying. Yes, I guess the first part of what you're asking, Mataroa, and that was remiss of me not to put that into the report, sorry, is that absolutely it'll still be presented as Māori and non-Māori, because it's very important that we continue to have an equity lens across all indicators, to be fair. And we will certainly work on ensuring that the narrative and the graphs support to actually tell a better story around actually what are we trying to achieve, and actually are we working towards that rather than just numbers and presenting those, because I think the way it's currently presented, it kind of is a bit interpretive, isn't it? And so definitely the move is towards the focus on equity and actually presenting better quality information that actually tells a story around what we're trying to achieve. That's definitely where we're trying to head with the new report. Does that answer your question?
Kind of. You know, I get what you're saying, but I think, wow, we've now been trying to sort of like, how does any of this actually also relate to the equity actions that are in the annual plan? I don't see all the links.
Right,
And so I can't sort of see what I might just be missing information or misreading it, but I cannot see how equity is being addressed in relation to these areas.
Sure, and I think that's there's a piece of work going on in the background in regards to looking at our different reports, and including obviously the equity dashboard, because and connection between the equity dashboard, the KPI dashboard, and the non-financial reporting, because there is connection, and what we need to look at is making sure that we're actually telling and linking that story between the reports in a better way. If that
No, that's all good. And so going forward, obviously you've picked up this work.
Yeah.
So going forward, who will be the key person for this?
For this piece of work.
Yeah.
So I'll just say that Deb is the responsible interim GM planning and funding. So this comes under Deb's watch.
I guess I'm just asking because I think it came up earlier too about that we have had quite a few people go, and that people's portfolios perhaps are increasing exponentially, and so I'm just signalling that must be a big workload for people who are covering multiple portfolios now. We haven't replaced Andrew, we haven't replaced I can't remember Kushla. You know, like there's a few gaps appearing, and I'm just saying that work's still got to go somewhere, and it must be piling up on people's workloads.
So I might just go to the Angela and Kushla one just to reassure you. I mean, we had an opportunity to think with the reform process, how would we better position functions within the organisation that would be consistent with the future. The team have worked incredibly hard to strengthen the next level. So whilst we might not have a Kushla and an Andrew, there's been a paper recently released around Sarah's third tier structure, which picks up some additional roles across her areas, but this particularly focused on cancer. And then similarly, I think we mentioned this in the weekly update, and I've mentioned it before, Lynn released a paper as well, and there'll be further. So we're strengthening at levels that we feel we need to strengthen, but we're trying to be quite mindful of what the future might look like for individuals and for our organisation as much as we can, because it's still a little unclear, I guess. It would be fair to say that in the planning and funding area there are gaps, but there are also some good people who are supporting this work, who are continuing at this stage. It wouldn't be. I mean, there's no doubt that the organisation is under pressure with the health reforms coming and individuals making choices about their future. There's an added pressure in that any individual, as you know, who is on an individual employment contract, the government's policy means that over $100,000, the expectation is we hold salaries. And so, there's a bit of a sort of a double whammy there that is, I think, we're seeing people moving around in different roles, people picking up roles at the City Council, for example, or in other bits of Palmerston North. So that's not an unexpected situation.
Okay, we've had some pretty good discussion, I think, in that space. So Karen, I think we'll make it the last one. We need to keep moving if we can. Karen?
Thank you. Just a couple of questions on those health system indicators. I'm just wondering, with that new reporting, is this, are we expecting other changes to reporting with the health reform changes in terms of transitioning, or is this just a one-off?
Kath, you're probably better. Please.
So these indicators were proposed ahead of the reforms.
Oh, okay.
I imagine there'll be a lot of changes coming, Karen. But in the meantime, that's what we'll be reporting against. I think for the until you know, until we're advised otherwise. You know, potentially, you know, the District Health Board will continue to exist, other than it won't be called the District Health Board and it won't have a board. So Health NZ, the District Health Board becomes part of New Zealand's largest Crown entity. And of course, then there's the Māori Health Authority that will have a role. So I imagine the changes will roll out over a good 2 to 3 year period, but I'm not envisaging that at the 30th of June, even this will suddenly stop.
Okay, just the 4 new ones that are highlighted in yellow, obviously that will strengthen our reporting, which I think is positive. One in particular that I am really interested in understanding is the people report they can get primary care when they need it. And I'm just wondering what the mechanism will be to capture that data, because whilst we hear that anecdotally people report that they are, you know, have delays in accessing primary care, I don't know when someone has tried to access primary care and hasn't been able to. I don't have an understanding of how they actually let anyone know that, or how that's actually recorded. So I mean, this is obviously the inverse of that, that people report that they can get primary care. So I'm just be good to understand how that's captured.
So there's an internationally validated measure, which is not what's described there, that we've been trying to capture from the PHO. We've had conversations with them. I think, Deb, you probably talk to them almost on a weekly basis, because we are very keen to get access to this data for obvious reasons, and that is time to next third available appointment. So we've been working, some of the bigger IFHCs are recording that and can report it. For example, Fielding Integrated Healthcare Centre uses that as a measure. So Deb, do you want to add anything to that? But that's something that we as a DHB are really pushing to get.
Okay, thank you.
So on the, excuse me, on the third next available appointment, the PHO is committed this quarter to having all of the practices that are in healthcare home actually working the process to report that. So we will hold them to that. But to answer your question, the data set for the where people report they get primary care is actually from the Primary Care Experience Survey, which is run nationally, then down through the PHO. So my perspective is I'll be really interested to know how many practices actually partake in that, so that we can give you a sense of what that subset of a subset is, so we can apply meaning or not.
Okay, thank you. That's really helpful.
Right, so I think we can consider ourselves done there. And Kelly, you were acknowledged. Where's she gone?
No, I'm here.
Kelly, you were acknowledged by the CE early on behalf of the board. Equally, we acknowledge the work that you put in and the time that you've been here. I certainly remember those early days, but it's quite terrifying, even being able to understand your language, let alone understand the numbers that you were throwing at us. But look, you've become a friend to us all, and we wish you all the very, very best in your next move, which we know is not too far. You're really still part of the wider collective. So good luck. Yeah, well done, mate.
Thank you so much. Thank you.
No worries. So we've got a resolution there to note note the highlights of the KPI. Moved by Jenny, seconded by Karen. In favour, aye. Against, carry. Financial update, Neil.
Thanks, Brendan. I'll pass to Daryl in a minute to actually work you through the specifics of the reports in front of you. But I guess a couple of observations ahead of time. When I think back at where we're at in August was, if you recall, severely impacted by COVID and its ability to operate theatres to do planned care. That had a significant impact on revenue. That cost us in the order of about $1 million as an interruption. Looking at this result, it's admitting that it's sort of coming back to a little bit of noise around the annual, or sorry, the year-to-date catch-up on budget. It's sort of not on the right side of the ledger, but it's sort of there or thereabouts. But it's largely, I think, impacted by staffing pressures. Same pressures are continuing into, and Kath's just giving you a bit of a heads up that October looks a little bit better. And the what I think we are here is sort of bouncing around about the line, which is just noise around where the budget thinks project we should be. So not great, not lousy, just within the margin there around what we would expect the budget to be. There are some underlying pressures though. Daryl's going to talk you through those.
Thanks, Neil. Welcome, Daryl.
Thanks, Brendan. Thanks, Neil. Yeah, I suppose just if there are probably three underlying issues in terms of the September result. If you also take into account the budget and the noisiness of that, we've obviously moved to a new budget now, an adjusted one with a $26 million deficit for the year. So we made some year-to-date changes, which included changes that we would have liked to have made to July and August, but obviously couldn't because that was already reported. So that's created a bit of messiness around September. I think the other thing that's probably a little bit messy is the timing of provider payments. So we have revenue that is quite considerably favourable. We also have provider payments that are quite considerably adverse, and that is just the timing of provider payments provider payments being made and the revenue that we weren't expecting to cover those. If you go back to August, it was exactly the opposite. So not concerned about the overall total in terms of provider payments, but they do come in some timing which is difficult to budget for, and so that always creates a bit of noise. Underneath that, there was obviously still some impact in terms of COVID coming through in electives, but still nowhere near the same impact that we had in August. I think the other major thing that is impacting is probably around mental health, and you'll see that the outsourced personnel is quite high, both from an adverse both September but also year to date. In terms of the year to date, about 60% of that is in mental health, the locum costs. There's a piece of work going on in that cluster to have a look to see what's going on in terms of locums and medical staff. The medical staff overall, the 478 is all largely in mental health as well. In fact, it's a little bit more than that. So I think what's happened is we've actually managed to recruit quite well into mental health, but we've also still got a lot of locum contracts which don't just easily come to an end. There's a piece of work that's going on in that cluster in terms of sizing for what is a reasonable workforce within that. Excuse me, that's my phone. Those are probably the key things. The other thing is obviously around the nursing. While the clusters, we put in additional cost savings in terms of the nursing around CCDM, thinking that they would not be appointed to. Still a little bit out of kilter from a year-to-date perspective, and I wouldn't be too concerned about the month-to-date. It's quite a significant month result, but however, adverse variance, however, that's purely because we adjusted the budget all in September. Look, happy to take any questions.
Thanks, Daryl. Vaughan?
Thank you, Chair. Just in regards to the holiday costs, how they're mounting from August to September, 500,000 figure. Does prompt the question around staff's ability to take leave, and with I know the pressures we got with the care capacity rosters. Can I get comment just to make sure that staff have the ability to take leave if it's in some form? Or is that just a mounting because there's a limitation around being able to have leave?
So the two aren't really linked, I guess, in a sense that staff are clearly still take leave as required. In fact, I think there's a push to take for staff to take as much leave as possible can over the Christmas period. The Holidays Act is really costs are really about historical miscalculation of the Holidays Act, which we're recognising both on a monthly basis. The majority of that is really about the miscalculation. So until we rectify the payroll system, and we're in line with all other DHBs to do that, we're not behind, we're not in front. But we're on a time frame that is, I guess, managed nationally. Those costs will continue to accrue.
Okay, just as a follow-on, Chair. So am I understanding that that's just been discoverable leave entitlements and not so much accruing month by month in the more current setting? Where does that 550 odd thousand figure come from between August and September?
So think of it this way. So bear in mind, last year we increased the provision. We did some work with Ernst Young to determine what over the last 10 years, how much we owed in terms of miscalculation of Holidays Act. And if you recall that the provision that we had at year end was $47 million over a 10-year period. So if you extrapolate that out, that's basically $100,000 a week that we are miscalculating because of the payroll system that we have and all DHBs have. So that is accumulating at approximately 400,000 a month. And we'll continue to do so until we've corrected the payroll system, and then we'll still pay that will still be calculated, yes, but it'll be done in the payroll system. Will come through as a payroll cost as opposed to one line Holidays Act remediation cost. Does that make sense?
Yeah, that's helpful. Thank you. Thank you, Chair. Thank you, Daryl.
So we've got the two financial reports there, August and September. Jenny?
Yeah, sorry, I was trying to figure this out, but I am going to need to ask your help, Daryl or Neil, because I appreciate it's going back to August and we're now, sort of hearing that there's an October result in. But just can you quickly bring me up to speed, because I'm just a bit stuck in my mind on the August report. On page 2, we note, sort of year end that it is, that we're forecasting a 23.6 deficit prior to holidays. Then we get to a 19.95 that's been approved by the board, and then obviously now we're looking at the 26. So I get that is that just simply because based on July, August, September, and from when we finally set it, we've just sort of rejigged that as we've gone?
Yeah, correct. Effectively, we've changed budget. If you like, in August, we were reporting against the 23.6 before Holidays Act and COVID costs. In September, we're reporting 19.6, I think it is, excluding COVID. And so we're just transitioned from, the old, the initial budget to a new one.
Yeah, and that's the one that's been submitted for approval. So the 26,195 is where we landed. We won't see that figure change in terms of our budgeted figure.
Well, we haven't heard back from the ministry, but there's no intention to change that.
Thank you.
And that is an important point, that we're in November and have yet to have a ratified budget figure, but we all understand that the system is the system, and so we're working as best we can within that. Rightio, no other questions? I think we're all done, so we can move to the resolutions August and September. Vaughan, you're moving. Vaughan's moving, and Oriana's seconding. In favour, please say aye. Against, it's carried. Thanks, team. So we're now moving to the sustainability plan. Judith.
Kia ora, thank you, Brendan. The report for this month, and I'll just give you a couple of highlights since the last board report on this particular topic. As you'll know, we had the board approve our 2 big digital projects, and they're now moving into the procurement stage, so good progress is being made there. On the Wellbeing project, the pilot of the new system and the resources and training has gone exceedingly well, and that project is also about to be rolled out more broadly across the organisation, so that is going well. Since the last report to board, you now have a dashboard with the non-financial measurements within the report, and this includes the baseline data that we currently have on some of our non-financial benefits. In the next report, you will have a report including some trend analysis, which will take us a further step forward in measuring our benefits. I also wanted to comment on a couple of things that FRAC indicated when they reviewed this paper. So the first was the financial measurement at the end of this report. The FRAC committee felt was a little bit confusing. So I'm working with Daryl to try and address that and to tighten up the financial reporting so that it's clearer for you. So that will be included in the next report to board. The FRAC committee also noted some concerns around the areas in red, and I'm pleased to report that some of the digital initiatives that we were struggling to get implemented have now progressed, and that includes the PIC tool and some of the other support initiatives around the coding project. So that has made some progress. And since this was last reported to FRAC, I've also been doing some intensive work while Selina has been overseas on the nurse specialing project. We now have a dedicated project manager supporting that work. We're doing some detailed analysis, deeper analysis on the specialing utilisation and trends across a range of measures that we can get data available on, which we hope will give us a clearer picture about actual utilisation of nurse specialing as opposed to just utilisation of outsourced nursing. So that work is in progress at the moment. I'll leave it there and see if there's any other questions from the board. Thank you.
Thanks, Judith. Any other questions? The only commentary that I would like to acknowledge is under benefits and savings on which is 3 on page 3. If I reflect back when you originally started all of this work, Judith, and the endeavours to find, genuine savings inside the machine, so to speak, those are serious numbers that you've managed to generate, 4.7 million potentially. And I just want to acknowledge that, because it's bloody hard work to be able to get everybody on board to understand what we're trying to achieve there. And though you might not be exactly on target, the objectives are strong and sound, and you're there or thereabouts under very trying conditions again. So I think that's worthy of acknowledgement, and just to say thanks for the effort.
Thanks, Brendan. I didn't probably say, but I would like to say to the board, I think we should acknowledge these are incredibly testing things to do in the current environment. And I'd just like to thank every member of the executive team for their ongoing commitment, and particularly the testing circumstances that some of these projects are being delivered in. I do think that's an important piece to acknowledge. I'm just at the backbone of a collation of effort. This is an organisation-wide effort.
Yeah, absolutely. Well done. Well articulated. Okay, so we'll go back to the recommendations. The Oriana's prepared to move the recommendations. Audit, you happy? Happy to move? I think so.
I'm happy to move, Chair.
Oriana moves, Karen seconds. I'll put that in favour. Please say aye. Against, it's carried. Well done. Thank you, everybody. Thanks, Judith. So now we've got Steve on the Tiala update. Welcome, Steve.
Good morning, all.
Morena.
I'll take the paper as read, but just draw your attention to progress since the last update, a little bit on regional, a little bit on national, and then welcome anyone's questions regarding the overall program. So in terms of progress since last update, the Digital Data Information Governance Group, DIG, endorsed a program and project governance framework to coordinate all the activities. We're going to need to take a program approach to the execution of what is now a substantial number of projects that we're getting out the door. So make sure that we coordinate across all the various projects and execute as per expectations. Also on the agenda later today, part 2, we've got business cases that have been significantly progressed. So the labs results sign off, the common web PAS as a service business case, and the electronic prescribing administration business case. So good progress on those, and obviously tabled for your consideration. Regionally, if I touch on that briefly, quite a lot going on there in terms of CIO engagement around creating roadmaps on the products. Importantly, I'll just note that there's been some additional resources or filling some gaps really around the regional operations model. A new ops manager starts on the 22nd of November. The regional CISO, the Chief Information Security Officer that we've mentioned a number of times, we've now got a fantastic candidate. He's accepted the contract, starts at the end of November, so that'll really help coordinate our approach to cybersecurity across the region. And we have a new service delivery manager already started. She started last week. Nationally, the cabinet paper that went up for the $400 million approval, likely an announcement imminent on that. That's all I really can say at this stage. I'll leave it in the minister's capable hands to communicate whether or not that's been approved or not. Other than that, everything's progressing. I suppose one of the biggest challenges we've got with the program is how we're going to resource up. I'll open it for any questions.
Well done, Steve. So in particular, questions of Steve, noting as he observed that later in part 2, we've got the real guts of the decision making. So if we're all comfortable there, we've got the recommendations which are to note accordingly. Somebody prepared to move. John's moving. Seconded by Muriel. I'll put that in favour, please say aye. Against, carried. So that's not rushing it through, Steve, but we know the bigger stuff comes later on.
Fabulous all. We'll see you later on.
Thank you. So KU, we've got the health and safety and wellbeing. Kia ora, Kaya.
Kia ora, Brendan. Kia ora, everybody. Kia ora koutou. Just picking up on the health and safety quarterly report. Just wanted to let you know that there have been no notifiable incidents or accidents during the reported quarter. The number of incidents have increased a little bit, mainly in the musculoskeletal injuries. So as a result of that, what we have done is put together a small intervention team comprising a moving and handling expert who works in the theatre, and she's been freed up 0.2 FTE from there, along with the occupational health nurse and the physiotherapist that we have. And we're looking at putting in some interventions to try and help with the musculoskeletal injuries, although a lot of them are not patient related, but we have observed that these have plateaued out. I also want to very quickly mention that we have procured some new equipment, 7 pieces of a new equipment called patient movers that we are training our staff on, and that will greatly reduce any patient-related musculoskeletal injuries as well. And they've just been purchased late October, early November. So that's happened. There has been a small drop in the number of health and safety committee meetings that were scheduled to happen, and that is mainly because of the response to COVID and not being able to have the kind of space that we had, but these have picked up again. Sick leave has been coming down lately. It did go up a little bit in July, but since then has been reducing. And the only other thing I would like to talk about is the annual audit from ACC. There was a technical issue that ACC picked up, which was about our self-assessment. We had used self-assessment tools earlier in the year where we came out pretty high, but what ACC wanted was a single place where they had the entire self-assessment. This matter has now been resolved, and ACC have cleared us from the audit with observations of continuous improvement. So rather than going on, I'm happy to take any questions. And obviously there are things about the fit testing, staff vaccination status, and vulnerability assessment, but I'm happy to pick up any questions that you may have.
Thank you, Kaya. Are there any questions, Karen?
Thank you, and thanks, Kaya, for the report. Just a quick question on page 3, the Kpi Dashboard, the vacancies. I realise this is as at the 30th of June. The vacancies was 105 at that point. Are you able to give us an indication? Obviously, we're a few months down the track now of whether that number is around the same or whether it's gone up or down.
So you're talking about the workforce report, isn't it?
Yes. Oh,
yeah.
Sorry, I've jumped ahead.
Yeah, no, that's right. I can still answer that. But I mean, what we have been doing is putting in a fair bit of effort both in the Maori recruitment workplace.
Probably from a order perspective, it might be best if we get through this paper and then move on to your next paper. Sorry about that.
No, sorry.
What have I got next? Mataroa and then Muriel.
Thank you, kia ora kea. I was just, you know, and it was in a previous conversation as well about annual leave. And I see there's an increase, and obviously that is maybe going to continue. I see the rationale around travel overseas and COVID, but I just wonder, what are we actively going to do in that space? Because if people aren't taking annual leave, they're going to get exhausted. If we require our staff to work harder or more or whatever because of COVID, if we get COVID into our hospital, it's going to fall over pretty quick because people are not taking leave. They're not going to be traveling overseas for some time. So I'm not sure that that reality, maybe there's, I don't know, what are the steps that we are taking? It's a bit of a disaster, I think.
I'm not disagreeing with you. I hear you. The increase, whilst consistent, is not sharp or huge. However, we have been putting in a lot of effort towards staff well-being and burnout over the last few months. So we're trying to manage the best we can in supporting our staff. And with the vaccination order coming in and a fair bit of anxiety around that as well, there will probably be a small drop in the number of staff, etc. So there will be some impact on the staff ability to take leave. Traditionally, though, we have seen a fair bit of leave, as much as we can accommodate, taken over the Christmas New Year period. Now, I have mentioned in my report that we don't expect to see a huge drop, but we do expect to see a fair bit, and managers are working and encouraging their staff to take the lead. So you have a genuine concern, and we are monitoring it. But what I can assure you is that we are putting a fair bit of effort on supporting the staff mental health and well-being, and burnout as well. We are monitoring that closely, though.
I might just add too that for staff that have excess leave, the position hasn't changed. Every manager is required to have a plan with that individual staff member around their leave. So that's because we've had that consistent focus to try and ensure that we don't see sharp increase in that 2-year plus leave period. So I mean, there are some areas which the board's well aware of where there is huge pressure on staff, and it is a real problem. For example, in midwifery, and we are very mindful of that.
And just in that as well, I think the directives from the CEO as well, even during COVID resurgence, was those who have booked leave or those who want to take leave must take their leave. So that's something, even the executives were on leave in phased manners, as we all were. So we are encouraging and trying to maintain what best we can in the best possible way, though.
So we have the strategies.
Yeah.
Which is good. So would we say then that we are satisfied that 100% of the staff who have that 2 years worth of leave or more have those plans in place? 100%. We're good with that?
Yeah, well, I wouldn't put my hand on my heart and say 100%, but we would be very close to say almost all. Almost all have their plans, because staff keep changing. Those numbers also keep fluctuating. The 2 years numbers keep coming up every fortnight with the pay. Those numbers keep changing.
Yep.
So yeah,
I understand that. I just wanted to seek some confidence that we were satisfied that actually the most we can do is being done, and we're monitoring that.
Yeah.
The expectation is that all staff with a leave balance over 2 years have a plan. And I monitor that indicator on a monthly basis with the business when they meet with me. we have a conversation around that.
Okay, thanks, Mother. Right, Muriel.
Thank you. Thank you, Claire. Mine was going to be a question about the non-patient facing incidents, but you really have answered that by saying that you've put a little team in to do some work there, because my concern was going to be, have we really overemphasised the support and training and equipment for clinical activities and maybe not paid enough attention to the non-clinical? So my assumption would be that the piece of work that you mentioned about the team putting some focus on this will actually address that. So I'm pleased to hear that that's happening. Thank you.
Thanks, Muriel.
Okay, so we'll move back to the recommendations, which are to note accordingly. I think Jenny's nodding to move. Is that right? Yep. So moved by Jenny, seconded by Karen. Yep. I'll put that in favour. Please say aye. Against, Karen. We've got one more report, and then we'll take a wee break. Emphasis on the first word. So we're moving to where are we moving to?
The workforce.
Oh, workforce update. KU.
Workforce update. Thank you, Brendan. So this is the key points of this report are that there are no significant variances on workforce trends. FTE and headcounts have increased across all professional groups except management and admin, and I think the turnover, as you might have picked up, has also increased in this particular work group. So the overall turnover has gone up slightly to 10.7%, but the overall turnover in management admin has also been creeping up a little bit. And I understand that there's been some information provided in the CE's report about that as well. In terms of, we've spoken about annual leave, we've spoken a little bit about sick leave, but what I do want to talk about some of the effort that's been going in about the Maori workforce, with the Maori workforce development, senior Maori workforce development officer having come on board and leading that process, starting with refreshing and reviewing a lot of policies, supporting managers in their decision making, and also reviewing recruitment processes and recruitment practices. And a report on that is also forthcoming. In terms of nursing and midwifery recruitment, I do want to point out a small typo, but with the extra effort that has been going on, and I think the typo that I wanted to point out was on page 5 of 11 of my report, where the variance for healthcare assistance for the month of August should have been -1. But this granularity of report does provide further assurance to the board about the benefits that we are making with the additional support within the nursing and midwifery workforce space. We also have now the light version of the online recruitment module that links into Kpi Health Jobs, which means we can now undertake a fair bit of data mining. It will also allow us to start developing our baseline data in terms of time taken to recruit, etc. So if we have to start looking at modifying and reviewing our policies and procedures, this will now provide us with a lot of support within that space. Rather than me going on about it, there was a return to nursing program that was scheduled last Saturday, and that continues to go up. But rather than going on about this, I'm happy to take any questions that you may have and respond to those.
Sure. We got any questions? Karen?
Thank you. Just returning to the issue I raised, which really did cross over both of those reports, the health and safety and workforce ones, and that is, I guess, the high level of turnover and high level of vacancies, and what the impact is on workforce of that. So what I guess I'm trying to get a sense of is, we get a bit of a snapshot, and this is quite a few months old now. This is at the 30th of June. So those vacancies, are we trending up or down? Or, yeah, I guess I'm trying to get a sense of where we are more up to date with that, or how that's trending.
So our vacancies are more or less consistent, especially within the medicine workforce, after having put in some dedicated support for SMO as well as RMO recruitment. We are really, really low in that. SMO recruitment is proving to be a bit more challenging than the RMO workforce. RMO workforce pretty much have 0 or 1 vacancy, and we have actually had to turn a few inquiries away because we did not have vacancies. Although when we say turn it away, we do keep them and continue to interact with them should we have vacancies further down. So when I say turn it away, we don't like just stop them, but that's what we're doing. The extra effort within the nursing and midwifery workforce has definitely resulted in a lot of benefit, because there is one-on-one interaction between this nurse and midwifery recruiter as well as child nurses, etc. So that has helped greatly. What has not particularly helped, and although, I mean, directly answering your question on the vacancy front, so yes, we've been trending and we've been going down a little bit more than anything else. So we, and again, I go back to the health and safety report where we've had that I've provided some information on the vacancies, and we are not definitely the lowest, but we are pretty low. So that's been going on. But I think the additional recruitment, I wouldn't necessarily call it barriers, but there are layers that have been introduced by both the Nursing Council as well as the Medical Council, and that have resulted in the recruitment periods being drawn out, especially for overseas candidates. But we're working through that. I think the best part is that we have enough knowledge of the process where we are able to help potential candidates going through the primary source verification, etc., which we need to do. So that's something that's really advantageous.
Okay, thank you. Thanks, Kay.
So we've got the recommendation there, two recommendations to note. Lou, are you prepared to move those? You happy to move? It's a move by Lou, seconded by Muriel. In favour, please say aye. Against, it's carried. So we've completed kind of like that section of the business paper. I just think we probably need a 5-minute break. We are a bit behind time. So we're going to have a little break now, and then we'll have another one in about 40 minutes time, I think. So can we come back at, what is the time? 10:30? Come back on at 10:30? Okay. Kia ora, Natalie.
Kia ora. Sorry, I'm trying to find.
We can hear you, you're all good.
Okay, speaker. Yeah, all right.
I just think we've got 1 or 2 more to come back on. We've just taken a very short break. Right, it is 10:30. Margaret, Vaughan, are you there? Yeah, Margaret is there. Vaughan, Jenny, Oriana. Right, we will kick off. So welcome back, team. So the next item of discussion is in our agenda is item 5.1, the Combined Medical Staff Association and Executive Action Plan. So welcome, Natalie. Great to see you on board. And in the McCall room, I can see, but regretfully I can't see who's in there.
So Tom Carter and Jeff Anderson. Sorry, we got plenty of lighting in here.
Oh, well done, guys. Good to see you. Thank you. Rightio. Do you, Kat, do you want to, Kat, can you kick this off?
Sure, I'll be really brief. Natalie and I have met ahead of today just to work through the action plan, which represents, I guess, a shared view of our progress against the items that were agreed between our executive staff and our combined medical staff. I think that the progress is highlighted in the actual action plan, which is appended to the report. And the one issue that remains ongoing or matter is the leadership of our clinical leadership of our acute and elective services team. And there's been a consultation paper released, which we're taking feedback on and will help us determine the next steps. There are some measures that will continue to be discussed at the MRG meeting and monitoring, I guess, some joint progress at that meeting as well. So it's probably better if I hand over to Natalie.
Brilliant. Okay, thank you. Welcome, Natalie.
Kia ora. Thank you for the opportunity to give you an update on our shared action plan. Colin unfortunately had to leave, go back to his clinical duty. So although he was going to be part of this meeting, he won't be able to. I thought it was a public meeting, so we were actually quite keen on joining the meeting earlier, but I understand that we were only allowed to be part of our own paper for discussion. So this confuses us a bit. But we do appreciate that the board.
Can I just clarify that? So my understanding is that, yeah, you're absolutely right, it's a public meeting, but my understanding is that all the staff are coming on as we go through the papers. They just cut in and cut out. So there's not an intent to cut anybody out. I think that you guys are here as staff, I presume.
Yeah, and yeah, we thought we could join the rest of the meeting as well. So I understand that normally you would just sit in the boardroom and attend the public meeting, which is a bit difficult, but I would think that we would be allowed to join the rest of the public meeting.
Well, let's not worry about that now. You're here, let's get on with it. Okay.
I do worry about it, but let's do that for next time.
Okay, look, Natalie, let's worry about it then. Let's get it clear. So my understanding is that the CMS are presenting to the board an update on where their view of the world is at. It's on the audit paper. Every other staff member comes in and presents their report and it goes back to their work. If the intent is to watch it via a public meeting, then I presume those staff members are on leave or whatever they are. I don't know all that detail, but let's just be clear, this is not an intent to cut anybody out. It is a Zoom meeting, as we don't normally do Zoom. We normally have them in the boardroom, as you know. But please, there's no intent to annoy anybody here. The media are online; they are observing what's going on as well. So let's get into the guts of what we're looking forward to, which is an update on where we are with the CMS in relation to all those activities that are occurring within the hospital.
All right. So we really appreciate that at the previous board meeting, we were informed that the board would like to be updated every 6 weeks, and we would like this to be continued. And the reason is that we're still far away on where we need to be. We have made progress indeed, but there's still a lot of work to do. And the paper submitted today gives an indication, but we also know, and Kath acknowledged it as well, it's more important for us to have the opportunity to talk to the paper. We have developed a document as well that we're happy to share with the board if they wish to, as be part of their documentation for today, but we don't have the support really to hand in everything on time. But as Oriana and Muriel pointed out at the previous meeting, that communication is on the top list, the open and honest conversations of our shared action plan. And that is indeed the key topic and has contributed, I think, to most of the issues that we have raised in the past. And we embarked on this process 2 years ago and it fizzled out, and we should not let that happen this time. So we appreciate to be able to update you guys. And then we would like to give you some examples of communication issues. So to work on communication in the future moving forward, I think is a big piece of work. It's not about what meetings are there and having a list of meetings, but actually how do we make sure that people are heard and listened to. And although the CMS knows that next year things will look differently, with the board being disestablished and a new leadership structure in place, the CMS is of the opinion that working on communication will also be key to start now, to make sure that next year, with a new structure in place, good communication, being open, honest and transparent, will continue to be a priority. So at the moment, we still don't think that is the case, and we'll need to work on that together. And we just wanted to give you a few examples of what that might look like and what the issues have been. And I just want to hand over first to Jeff, and then Tom will speak as well.
Hi, everybody, and again, echo Natalie's thanks, and I'll also echo that we're making slow progress, but we're nowhere near where we need to be. And we tried to improve communication in the past, and as Natalie says, it fizzled out, and we don't want this to fizzle out. I want to talk specifically about the SPIRE project mitigation. As you know, we've sort of very reluctantly accepted that SPIRE is the only option available. The Minister's Chief Medical Officer, Dr. Connolly, made it abundantly clear to us that if the DHB doesn't go ahead with SPIRE project, we go right back to the back of the queue for anything at all. And so we sort of feel we've been pressurized into accepting something that we've very, very little confidence in. The initial low-hanging fruit, the bit that was going to be easy, apparently, was to sign a contract with Crest Hospital to enable them to build an operating theatre that would enable us to outsource or outplace more patients. The board, at the last board meeting I attended, which was over 3 months ago, you were told that that contract had been signed, and then a Crest board member pointed out that it hadn't. You were told it would be signed imminently. As far as I'm aware, it's still not been signed. That was the low-hanging fruit. That was the easy part that was going to enable Crest to help the DHB to mitigate SPIRE.
Can I just interrupt you there, guys? Look, I'm sorry, but this sort of discussion is not the forum in which we should be having it. Now, I'm sorry, but this
I'm sorry, but we've got to discuss it somewhere, because when we discuss it anywhere else, we get told that that's
processes are inside the machine. But I have to say to you that the idea, Natalie, is to bring to the table those concerns beyond which those can be organised inside the machine. Now, I have clear understanding that all these issues are being worked with within the management team. What we need as a board is what are the specific things that the board need to respond to. Remembering, we're sitting here today, you have a vote of no confidence in us.
Yeah.
Not had any response.
And we need something that will re-establish confidence, because it's not happened yet.
And I'm sorry, but having this sort of presentation is not adding the values that we are looking for. Now, we know that the SPIRE program is underway. We know that the contract is resolved with Crest. We know that management have got all these things in place. I'm sorry, but this is not the forum to have discussion. So, Natalie, with respect, can you please take over the lead on this?
I've said what I have to say, and I'm speaking on behalf of the medical staff of the whole hospital, who, in the vast majority, share my views, and the board needs to be aware of that.
I'm sorry, Jeff, but you're out of line with the commentaries that you're making, and you don't represent the full organisation at all. So, Natalie, please, can you take the lead on this?
I wonder if I might just come in and just reassure, which I have had this conversation with Natalie. The key point, I guess, around the SPIRE contract is that it is agreed. We've been working and negotiating the finer detail of the contract, and in fact, in these board papers, is the board following a submission to FRAC, the board has the delegation, I don't. So there is the board approval sort of the contract that has been agreed with the board and management of Crest, which is for a 5 with a further renewal for approximately $30 million. So And I've also signed a whole range of additional contracts with Crest, which relate to our ongoing programs of work with Crest. So we have an additional contract for endoscopy services, which has been signed, which are needed to support our endoscopy service while SPIRE's being built, and also an extension of our outplace services. So this is one contract, but there are multiple contracts that are in place with Crest. Anyway, that's just to kind of ensure we're all on the same page.
I would like to comment, though, that this is an example, and that is really my key point, of issues that are ongoing with regards to communication. We have documented at several meetings that that contract would have been signed within 1 to 2 weeks at several meetings, and it has not been the case. So that is just an example, and it's not just about the content of this topic. It's an example of where the communication goes wrong. We are repeatedly held by the hand and said, it will come in 1 to 2 weeks. And it doesn't happen. And if it is not going to happen, just be honest and tell us that we're waiting for the FRAC and we're waiting for the board meeting. And I would like to continue, because this is just an example. And I think this is relevant to the board, that the culture of communication, and that's been the key here in this hospital, the culture of communication is not right. And that is important to the board to know. We want to work on that, but we just wanted to give you examples of where that sits at. And you can blame us for that, but we've got a lot of staff behind us that want this to be addressed. So they are examples of the core issues, and we need to address them. There's a lot of work to do with regards to open and honest conversations in both directions, being heard, listen to what staff say, and don't deflect that. And that is an issue. And I don't know about you for the board, but we have to scrutinize everything. We need to check on things, because our experience for years, and I'm also referring to my colleagues, we need to do that. People are not happy with this. So that is why we are raising it. And we think it's relevant to the board. You might not like to hear this, but it is relevant. We also are definitely dedicated to work on it, as we have, and as I've said, and also in my introduction, and we will. But we want to we want to make sure that the board is aware of these kind of communication issues. And I've got a few other examples that I'm probably not going to mention them for today. I'm happy to submit those in paper if the board wishes to. But yeah, I just wanted to make really sure that there is a big piece of work that needs to happen still. Otherwise, we don't want to go back to where we were earlier in the year.
I just think, Natalie and board, I think this is an example of where we maybe talk past each other, where we say we want to agree with Crest, which doesn't literally mean a signature on a piece of paper, because that takes a long period of time. And the negotiations have been happening between Alberto Ramirez and Lynn Morgan, who have been meeting weekly with Crest to ensure we've got an agreed contract. As you'd imagine, a contract of this size has been through Crest's lawyers, it's been through our lawyers. This is just normal business, Natalie, and I hear you, so I guess it's for me, it's to think, how do we communicate that progress? If this is an item of significant interest to you guys, then I apologise, because we could update you on a weekly basis if that's what you guys need.
So Natalie, my position is probably very similar to the CX. I just cannot believe that we're having this sort of discussion. We've signed off on SPIRE. We're locked and loaded with the program. We're expecting to have the contracts in place necessary to deliver that project. We've got a timeline and budget set aside for it. And there just seems to be unrealistic expectations about what a specific statement says and what it actually delivers. So we all know that the Crest deal is a game breaker. We have to have that. And we all know there's a whole lot of work that goes in the background to achieving that. It's achieved. So
Brendan, I've got my hand up. I just want to make a couple of comments.
Yeah.
One is, I think we are trying to build a trusting and open and transparent relationship between the board and the combined medical staff, and obviously with the executive alongside of us. I think the opening of that door is still quite new. And so I think that trying to have this conversation on Zoom is fairly fraught. And I feel like I don't want to be party to being disrespectful to people who have made time to come. I don't think talking over each other is a useful way for meaningful and open communication to occur. So on the basis of that, I feel like there are some things that they would like to share with us. And I do wonder if we, I don't know if we postpone the more detailed conversation about the culture of communication, which was referred to. So two things, one was about the culture of communication, and then secondly, there were some examples. And I feel like we're going to, it's not a constructive way to do it on Zoom. And so I think in the interests of respect for everybody and in the interests of wanting to have constructive relationships, I think that we should make sure that at our next face-to-face meeting, we have a really good way of engaging in this dialogue. That's my view. I don't want to be talking over others. It's actually quite distressing when you're someone on Zoom and you can hear that going on. It's not okay.
Yeah, okay. So Natalie, you might have a view?
No, I would appreciate that. Yeah, I would really appreciate that in a face-to-face meeting. And I also understand that this is awful to do these kind of things via Zoom. So I'm happy to work with Kath and with the CMS to prepare for next meeting on how we're actually going to deal with this. And I'm glad this happened. Sorry, it might have been distressing, but this is what we experience many times. So it's hopefully giving you some insight.
So Natalie, would you be prepared for you and I to meet and have a chat?
I'm happy to do whatever it needs to move this further. And I think a representation of the combined medical staff in a smaller group of the OLT is fine. Whatever is needed to move this further, but this needs to move further. It's not okay to let this go.
So I think we've got an understanding that you and I are going to meet up and have a chat.
I think, Brendan,
it's more than a chat, Brendan.
You'd set up a small action plan group. I don't have a hand raised. Sorry, I've been sitting here with my hand up for quite a while. This is Tom. We had set up a small action group to lay out the ideas and the goals and the shared action plan, and everything we talked about has fallen short and in pieces, I would agree. As we've demonstrated again with bad lines of communication here today. But that small group should probably be reconvened. And if you want that small group to include members of the board, or I forget which parties were at it again, and to have a little bit of a pre-meet to have an idea of what we're trying to deliver. But I would probably reiterate that most of our communication is that, by the way, CMS isn't happy and moving on with business as usual is what we feel like has happened. Not actual open and honest and frank conversations. So I would just reiterate that was one of the main goals that we said we were going to come to after all of our meetings with Andrew Conley and everything else like it. And we all agreed we would hold each other to account. And I would thank Matara for doing that and holding us to account to have good, open and honest lines of communications. But it's not easy when issues are contentious. So I apologize, I can't chat and do anything else. I did have to just pipe in. But I think reconvening that group, making sure we're clear that this hasn't really opened up and we haven't gotten any progress in 3 months, we have to have those clear lines of communication.
Okay, so I'm going to respond, and then I think we're going to have to call this discussion to an end. So I'm going to respond as chair to say I reject most of what has been said, Tom. I have to say to you that I've looked pretty damn carefully at all of the structures inside the organisation that the CEO and the executive team are responsible for. And I am really impressed with the level of opportunity to engage. Now, if I reflect on today, essentially one person made a comment that there is no support or very little for the Spire project or the trust in it, or words to that effect, and then walked out. So that's not terribly helpful. My expectation today, and you know that I'm hesitant about it, was that constructive observations would be being made to us at a governance level for which we can respond. Everything brought to this table so far is at management level. It is absolutely at management level to deliver Spire and engage appropriately. And I'm sorry, but this is not the forum for this type of discussion. I agree. But so my position is this piece of discussion is now concluded. The CEO has a responsibility to engage with you as employees within the organisation, and I'm clear that the discussion is now finished. We thank you for your participation, Natalie and Tom, but clearly there's some work to be done between management, the executive team and staff to get some clarity on those points that are not being articulated properly. So we're going to call it quits at that. That's it.
Brendan, just one final comment. I think you should include, if you're going to meet with Natalie and Tom in a small group as a team, that you should include your two co-chairs.
No, I'm not going to go down that path. I just made the proposition to meet directly from chair to Natalie. I'm not going to participate in other groups because that's inappropriate as a governor, to be frank.
Well, hang on, we're a board.
Yeah,
Brendan. So let's have a discussion about this as a board, because it's our discussion and our decisions.
So I'm just saying.
So hang on.
I'm not meeting on my own. Okay.
No, that's fine. So Oriana's point about meeting with both John as chair of PDAC and Oriana as chair of FRAC. That actually balances out there, and I fully support that as a board member.
Yeah, so we can have that discussion, separately in our board only time to resolve where we might go next. But just on the public record, I made it clear this is governance and management separation. Nothing that I've heard here is of a governance nature. It's management to get on there and sort it out. So we're going to stop it there, and we're going to move on to the next item on the order paper. We've got a big agenda to get through. So thanks for the engagement so far, Natalie, and I'm looking forward for your engagement with the CE to further this project.
Excuse me, Mr. Chair, is there the opportunity for board input into this discussion at all?
No, not now. We're moving on to the next item. We're done. Okay, we're done. We're moving on.
I'm not happy with that outcome.
Okay, thank you. So we're moving now to the next item, which is the DHB and MWH combined board work update, work plan, please. Tracy?
Kia ora koutou. Gosh, my wider was a bit all over the place. I have to apologise. So just moving on to my report, I just want to say that I was quite delighted in writing this report. I feel like there's been quite a bit of work that has been positive in this space, and I'm specifically happy with the work that's gone on in relation to the new equity resource that's gone into the providers. The 3% uplift and the increased resource of $3.7 million is almost all contracted out. Providers are delighted with that increase and are starting to talk about how that is assisting them to continue with a wider berth on the existing services. And in addition to that, I just want to raise the excitement really in the community about the 4 rongoa services that are now out in community. Those have never been contracted for, and providers are feeling very supported in that space, and they're able to take on more clients. So we're just working up with the Ministry of Health to support those providers a little bit better in the areas of rongoa. And also the Ministry of Health are delighted that this district is now taking those services on as well. Other than that, hopefully you've all enjoyed reading the report, and I'll take any questions. This report is also going to Mana Whenua Hauora, and the report at the back, which is appendicized, is being discussed this afternoon, just to see if it fits for us moving forward to the end of June 30, 2022, or whether it needs tweaking. Kia ora.
Kia ora, thank you, Tracy. Are there any questions on the report or comments? Just on page 9, it says that Te Whitikita Order has not met since November 2019. Is that correct?
Yes, as far as I understand. But however, Oriana, you might want to chip in here. Oriana has been speaking with each of the chairs in the interim about their developments and what's taking place in their districts.
So in terms of Whitikita, that is correct, that we haven't had a formal meeting since then. One of the issues is, and it's described in the report, is that Whitikita isn't actually resourced. Each DHB decides for itself how they're going to support their iwi Māori relationship partnership board, but the Whitikita really runs on the good graces of its members. And Shane Walker was actually going to raise that at the chairs group, that if they're not resourced, some are better resource than others, then why should they put in any efforts? That's basically what it is that some of them won't put in any effort because they are just not recognised to do anything. So that's for some of our, I'm not talking about MidCentral District House Board specifically, but for some of the others, that is their stance.
Okay. Are there any other observations, John?
My concern really is around, we've managed to look at COVID as an area that we should be pivoting towards in terms of supportive care measures. But look, our failings in terms of oral health as a district health board and immunisation, I think, need to be considered, because these are long-standing issues. COVID, it will become one of these, and I think it's something that we should talk about for the future. I think it's something that the MHA and Health New Zealand may wish to take a more active role in. Thank you.
Okay. Is there
any can I just reply to John's comment there? And I want to refer to when the minister was in Taupeni Hinare recently, and we raised that, John, and said that while all our attention at the moment is on COVID, that as front-facing providers, we still have to retain the trust and confidence of our hapori, of our communities. And what we said was that the message around get vaxxed or else wasn't helpful in terms of retaining the trust and confidence of our community. So there needed to be some messages coming nationally to say that while vaccination is what we should all be aiming for, we understand people's attitudes and responses, and we will continue to work with them in terms of getting people over the line. So that was a particular concern of our providership, was we are all behind as providers, behind the vaccination drive. There is no question about that. But when this is all over, or when we get over the hump, or whatever we want to call it, that we still have to be out there encouraging our communities to engage with the system, particularly around things like oral health, immunisations and screening programs.
Yeah, no, I understand that, Oriana. It's not something that I wish to burden the Māori providers with or mana whenua hauora to this. I think it's a comment specifically for the DHB and looking forward to how those relationships can be better supported by Health New Zealand and the MHA.
Thank you, John.
So one other, just if we go down to page 14 under E for equity, and I'm just trying to understand, it says in the third column across, the incidents of racism and discrimination are recorded and reported against twice yearly. No, my only question is how and to who?
Yeah, so that's an issue that Kaya and I are working through, actually, Brendan. It's quite difficult, especially if it's not organisationally reported.
Yeah.
So I'm hoping this afternoon when we have the discussion just about, you know, whether this fits the bill for us between now and June next year, whether these are the right things to be reporting on. You know, I'll take your advice, the two boards' advice on that.
Okay.
Because often those discussions happen at a service level, and then what happens is Pi order gets pulled in, and the only way that we would be able to report that is through our team if it does come through us, but it won't be consistent.
Yep. Okay, so work in progress. Where's Tracy? Yeah. I'll just identify one other one because I think it's really, really important. We go right down to the last page, the very last on the right-hand side, joint communication strategies developed and resource for mana whenua hauora and MDHB to ensure a cohesive approach. And my question is budget, making sure appropriate budget is set aside to do that. Who and what budget, you know what I mean?
Yeah, so we've only just had Emma come on board, so we started that discussion last week about how we might be able to ensure that what we're doing is right by both boards and we've got the right communication plan going forward. Because if you think about it, we've got communication plans for Africa right now, so we don't want to be being unwieldy or overwhelming either boards.
Okay, are there any questions? No other questions of Tracy? No, so we've got the recommendations to note the progress to date. Prepared to move. Move Muriel and second by Lou. In favour, please say aye. Against, it's carried.
Chair, excuse me, just a question of following business. Are we not going to note the CMS report at all? There was
no, fair point. Yeah, absolutely right. No, that's a fair point. Let me just go back. Yes, we should. And for process, I'll move that we note the CMS report. Is there a seconder? And seconded by John. I'll put that in favour. Aye. Against carried. Thank you, board. I apologise. I should have done that.
And there wasn't no opportunity to speak to that, was there? Or are you leaving that for a part 2 session?
Yeah, I think that's the wisest thing to do, Vaughan, to be frank.
I do think we need a follow-up, a conversation.
Yeah, we will. Yeah. We'll have it later on. Yeah. Okay.
Thank you.
So thanks, Vaughan. We're moving to the midwifery workforce update. 5.3.
Thanks, Brendan. It's me, Sarah. Brendan.
Sarah, we're right.
Thanks very much. Kia ora koutou. I'll take the paper as read. Just a couple of key points that I just want to raise with you. So we have got 3 new graduate applications processed now, and we've got job offers out for those 3 posts. And we have got 1 additional person now interested in return to practice, which is excellent. We still haven't managed to progress with the Otago Polytechnic nurse to midwifery transition programme. However, I have had a discussion with AUT in the last couple of weeks, and whilst they haven't got their programme through council at the moment, they're hoping to have it approved and be able to start by semester 2 in 2022, which is good progress. 18 midwives are now engaged in professional supervision. We've extended that to a 12-month period, so that will finish in June, so we can have a really good evaluation of that programme. But the uptake is really, really positive. We have now also recruited to the clinical coach role, which will be in post for the new graduates to start in January. And we continue probably to work really hard to find an alternative location for antenatal clinic. Antenatal clinic will temporarily move over to the birthing centre from the end of the month as part of essential COVID work that's occurring. So it's only a temporary move over to that location. Finally, just to say that we're having a real strong focus on consumer surveys, and you'll see in September we only had 16 consumer surveys returned. However, for October we've got 65. So we're focusing really hard on that to make sure that we get a good uptake. We're getting really good feedback from our consumers using our service. Thank you. Happy to take any questions.
Brilliant. Thank you, Sarah. Are there any questions on Mataroa? Kia ora.
Kia ora, Sarah. Thank you for the report. Hang on, I'll just go to the page. So my first question, it relates really to your update about the number of surveys received.
Yes.
Because you were sort of saying in there, the consumer liaison coordinator is undertaking a targeted review process to ensure response from Māori whānau. So is in the new batch, I'll call it, are we satisfied that Māori proportionately are responding to the survey?
I think that's great feedback. Thank you, Mataroa. So I've only just heard actually about the numbers that have come through from October. So Harpai, our consumer liaison, is actually working through those at the moment, and that's one of the questions that I've asked. So hopefully I'll have some more information for you at the next meeting, if that's okay.
That's perfect. I have a couple of other questions. I'll just carry on. On page 5 under communications.
Yep.
Hang on, I'm just trying to open my thing. Just around the culture survey, which was released in July. I was just wondering, what are the key findings from that survey?
Thanks, Mataroa. Yeah, I'm really happy to share that. If you'd like us to put it on Stellus, that you can see the outcome of that. Clearly, you know, the vacancies have an impact on the staff wellbeing, and that's clearly evident from the culture survey, and that they need, there's lots of actions that they want completed. So we've done a current state and a desired state. So we're working through that with the wider leadership team at the moment. We're having weekly meetings with them to try and tackle some of those issues, really. They talk a lot about feeling valued, and we've been trying to get to the crux of what that matters, because we've addressed the big issues, you know, supporting them with additional payments, retention payments. We're supporting them making sure there's food available because of the acuity on the unit, but there's other issues. So we just want to make sure that they feel fully valued and make sure we've got the right leadership team in place to support them.
So yes, I would appreciate being able to see that on Stella.
Really happy to share that with you.
And then my last question is around on page 8 under clinical safety, where it's saying about increased ward clerk support from June 2021.
Yes.
In progress. So I would have thought that wouldn't be too hard to resolve, getting some extra admin, or am I wrong?
Yeah. Yes, that would be the assumption. Unfortunately, we've had some people leave, so that's been the problem. So as we thought we'd sorted it, then we were on the back foot again. So yeah, we are absolutely trying really hard to sort that as a matter of urgency for the team.
It would be, I don't know, but it could be good to have definitely a Māori face in that admin space, right?
Yeah.
So, privileging Māori applications, because given the rate at which we use those services.
Yeah. Probably the one thing I didn't mention, Mataroa, and it probably happened after we'd written the board report, is that we're in the process of recruiting to a midwife specialist role as well. That's going to work across primary, secondary, to make sure that whānau Māori are supported really well in the space. So we're really excited about that role, and we're going to be interviewing, can't remember if it's this week or next week, for that role as well. It's good.
Great.
Yeah. Thank you.
Thank you.
Thanks, Mataroa. Karen?
Oh, thanks, Sarah. Just looking at bottom of page 3 under the clinical safety 3.3, there's a comment there about changing operational hours to Kpi Birthing Centre early next year. And I'm just wondering, would that actually reinstate it to its full functioning, or is that still, would that still just be a partial functioning?
We are really hoping to be able to move back to a 24-hour service from probably around April next year. We have got some interest from some LMCs that are keen to come and to work with us next year. So that hopefully will only be able to do primary births there. We won't be able to do postnatal transfers at if we reopen 24 hours. So it'd be a midwife and a HCA staff in that place. So we are working really hard to make sure we can do that. But obviously we're not going to be able to do that at the beginning of the year with the new graduates in place, because some of the people that are coming on board are not coming on board until about April, the more experienced midwives to enable them. Thanks. Thank you.
Jenny?
Sarah. So is that more experienced midwife that you talk about in April a pipeline of perhaps someone returning from maternity leave, or have some LMCs indicated they will switch over in April of next year?
So we've had some interest from some LMCs as we've gone out and said, is there any way we can, you know, encourage that support of the birthing centre to work together? And we're just working through some of the intricacies around that at the moment. And Selena and I are tackling that at the moment.
Okay, so early next year is now April. So
yeah, absolutely.
Sort of
I think we have had we've had one ACM go on maternity leave. We've also had another ACM who's moving to a different part of the country. So that is impacting on our ability to do it any earlier at the moment.
So we continue to be a bit one in, one out. We're stagnating at that, are we?
Yeah, definitely.
So my question just is what you put in your report and then briefly spoke to around the significant concern from the midwifery sector around the relocation of that clinic to Te Papaioia. And then you said, but that is now going ahead. And I think you mentioned COVID. So I guess my questions as governance for a reassurance in a workforce that already is, both vocal, concerned, and we're shorten. Where are we at with buy-in from them, or what are we doing to? Is there a general consensus that this simply needs to happen? And can I please, just as governance, understand what you mean by why we're needing to do it because of COVID?
So there's work going on across the organisation around COVID resilience, and as part of that we need to open up some beds, some additional beds, and where antenatal clinic is currently will be made into some beds for a temporary period. Now I think it's really important to reiterate that this is a temporary process, so it's not a permanent relocation. We've been very clear in our communication with the LMCs and the core staff that this is the case, and with our antenatal colleagues as well. So we will, this is probably for about a 4-week period, and that's a process. So we've made that very clear, Jenny, to people.
So Sarah, why do we then suddenly, if COVID's our reason, not need those beds in 4 weeks' time? Or is there that another option for that clinic to relocate, another venue is coming available after 4 weeks?
We are working incredibly hard. So the work that's going on around COVID resilience is a temporary piece of work, and actually we'll be able to reuse that space after that's occurred, if that makes sense. But we are working on other solutions at the moment in the background.
Okay, thank you.
Thank you.
So we'll go to Jeff and then Vaughan.
Yeah, thank you. Just to address the timing of the reopening of a primary birthing unit, the worst thing we could do for the public and the expectations is to have a stop-start, open-shut, open-shut. So it's absolutely critical that we are robustly able to reopen. And if that means a bit of a delay, if it's April or May rather than February or March, then it's critical that we do that. And just to reinforce what Sarah said about it, Ward 24 has to close to be refurbished to be able to look after COVID. So we have to find space, and the antenatal clinic where it currently is the only space available for that 3 to 4 weeks. So that's the temporary nature of that.
And thank you for that context, Jeff. I just think as a board member, given, we've been challenged by this workforce in the past, that's just why I wanted to completely understand it. Then I'm clear too on, any response that I may need to give to. So thanks for that added context.
Thanks, Jenna.
Vaughan?
Thank you, Chair. Just in regards to the recent correspondence from the New Zealand Midwives Collective relating to the legal mandate from the Ministry, from government, around the number of core midwives in the LMCs, indicating that they weren't going to be going to get vaccinated. Is that an immediate concern in context of midwife staffing levels?
No, currently it's not.
Okay, thank you.
Thank you.
Selena, I thought you were reaching forward to say something there.
No, I wasn't, thank you.
Okay. All right, so we're all good. So we've had a good discussion on that paper. We can move back to the recommendations, which are to note and note. Are we comfortable? Moved by Lou, seconded by Oriana. I'll put that in favour, please say aye. Against, it's carried. Nursing workforce update.
Thank you, Chair. Through you, Chair, I will take the paper as read, and as you can see, I've got a very bad cold that I've brought back from the Northern Hemisphere with me. From our discussion at the last board meeting around the shifts below target, I can see that we have put into the paper around the mitigation that the IOC undertake, and I hope that has given you some reassurance, and we are starting to see improvement in all the metrics, and particularly around our shifts below target from the last paper. I'm happy to take any questions.
Brilliant. Is there any update on how the Saturday the 6th of November went?
I believe it went ahead and it went well.
Okay.
They'll be pulling the numbers together, and I'll probably have a fuller report by the end of the week.
Yeah, I understand no midwifery return to work people attended, but there were a small number of nurse return to work, Brendan.
Oh, good. Okay. Okay. Brilliant. Are there any questions on Selena's report? Are you hand up, Vaughan? Is that old or new? Old. Okay. Anybody else? We're all good, so we can move to the recommendations there to note the nursing workforce report. Somebody prepared to move Muriel, and seconded Mataroa. Put that in favour, please say aye. Against, it's carried. We're now on to the Technical Advisory Services report from Debbie.
Thanks, Brendan. So just seeking an endorsement of a representative to attend the AGM.
Yeah. So that's just a process thumb, prepared to move. Is there any discussion? All happy? Prepared to move. Move Oriana. Second Muriel. Put that in favour, please say aye. Against, it's carried. And the Allied Laundry Services AGM, again, an appointment procedural process. Somebody prepared to move? Who's that? Move Vaughan, seconded Lou. Put that in favour, please say aye. Against, it's carried.
Sorry, Brendan, you went really fast. Can I ask a question about that?
I'm sorry. I'm sorry. Question on?
Oh, just about the Allied Laundry.
Sure.
So in terms of the Allied Laundry being a regional service, what is the input into the this upcoming legislation around the 3 waters, around the drinking water standards, and around the whole new freshwater standards? What input do we as a DHB have into that space, given that our laundry is a big contributor and a big user of our region's water supply?
Is that you, Neil?
Doesn't feel like a good pass to get, actually. Thanks, Ariana. So in terms of, I can't identify specifically any input that has been requested or opportunity made for Allied Laundry to actually have feed that I guess we are just a large user. What I can assure the board is that the discharge standards from that laundry are probably the cleanest, the best treated that actually go out through the Palmerston North system. There's a significant work put into making sure that they're pre-treated before they leave the site. Yeah, and beyond that, I can't really comment.
Yeah, that's fair. That's fair.
I was thinking, Neil, as you know, that was when we first accepted other districts' laundry, that was my huge question was around, you know, how good is that? And we did actually have a tour of the upgraded system when it was installed. So it's really just around, you know, there's so much going on in the freshwater space that I'd imagine through our public health and the regulation team, there's been some input. So thank you for that. And I see Mataroa has a question.
Yeah, Mataroa.
Kia ora. Mine is probably not dissimilar to Oriana's. And you sort of partly answered it, Neil, in talking about the emissions. But, you know, this is actually quite a big issue because, well, people would have seen COP26, you would have seen locally the Three Waters. It's not something we should be putting our heads in the sand on. We should be, and there was nothing in the minutes from the AGM, no discussion. So I just wondered how aware are the people who are leading Allied Laundry about these matters? And could we link up a bit more with public health and with some of those wider aspects?
So if it is helpful for the board, I can put the question to the Chief Executive of Allied Laundry and look for an update on what the current usage, what the mitigation strategy is. What I'm aware of is that the laundries typically have two main issues, apart from the fact that they do draw water off the freshwater system, which is unavoidable. I can assure the board that they have a water recycling process there, which makes sure that every bit of water gets used about 4 times before it's done, that they have a significant delinting plant that achieves extremely high qualities of reduction in anything coming off it before it is actually discharged, and that there are balancing dosing plants to make sure that the water discharge is not chemically unbalanced. And beyond that, I'd actually have to go and ask Mark for a specific comment to give you further insight.
Thank you, Neil. I would appreciate that, sure.
Okay, so it looks like we can go back to the recommendation for the Allied Laundry, which is the annual general meeting and the appointment of. Somebody prepared to move? Moved by Vaughan.
You've actually done that one, Brendan. We've got Vaughan and Lou.
Oh, sorry. Thank you. More organised than I realised. So, of course, I mean, the 2 questions afterwards, you're quite correct. Thank you for that, Margaret. Rightio, so we've done, so we've got the health partnerships item, which is an information paper from Neil. Anything to add there, Neil?
No, probably 2 things to note. The health partnerships over the years had a massive investment into IT and what was originally the finance procurement supply chain system. Since that was revamped about 2-3 years ago, it's both parts. The FPIM system, which is the financials, is proceeding and onboarding, and the health system catalogue is actually also making extremely good progress in its implementation.
Any specific questions? Prepared to move the resolution tonight? So prepared to move. Moved by John, seconded. Selena's waving her hands, but I can't use her. Vaughan, put that in favour, please say aye. Against, it's carried. We've got the board work program on 6.2. Are there any observations on the board work program? Any concerns around what's set out there? No, we're all happy.
Yes. Yeah, sorry, I do have my hand up. Sorry, Brendan.
Oh, sorry, Karen. Yep.
Just a couple of questions. The annual plan and budget that's indicated that there'll be papers coming for 5 of those meetings. With that, the responsibility of the 2022-23 annual plan and budget not sitting with the board and that being transferred to the New Zealand Health. I mean, like, what is the purpose for those papers? Or what is our responsibility if we're not required to confirm an annual budget and annual plan for next year?
Yep. I'll get Kath to help clarify that because there is some participation.
So we got a letter on Friday from the transition unit that set out the process for us to follow. So there's a little, I mean, things are still changing on a regular basis, but I think that it would be, I think I would value, and I'm sure the team would value, the board's engagement in the work that we're doing to ensure that this organisation is, you know, that you're cognizant of the position or any risks that might be emerging. But, you know, happy to take that off the board's work program and include that in the transition reporting if that feels better.
I'm not necessarily suggesting it should come off, but just want to have a clear understanding of its purpose. I mean, if it is to help inform the direction of the organisation, that's fine. But is it just without the usual sign off by the ministry?
Well, no, it won't look like our existing annual plan and it won't look like our existing budget, but it's you know, and that's still being worked through and could change in multiple different ways over the next 6 months. But at this stage, there's a strong desire to have the inputs from this district health board to support the budgets being established for the different bits of Health NZ by the end of February, I think, Neil, it was, wasn't it?
Yeah.
Okay, thank you. And just one more question, if that's okay. The next line down, the workforce strategy, there isn't a report plan for the next 6 months. Is that just an oversight, or I would have thought that was still quite an important area for the board to keep an eye on?
That's actually a strategy. It's not the reporting. That's that's developing a strategy.
So the reporting is still the next part down then.
Yeah, we'll still report, but we won't be establishing a new DHB strategy, I think, or a new DHB plan, because that, I'm not quite sure with the workforce strategy when that was due. Like you can see for the OD plan that was going to be due in November 22. I can follow that up, but this is not the reporting against workforce.
Okay, I see there are some reports under workforce further down, so no, that covers that. Thank you.
Oriana?
Thanks, Brendan. I just want to go to, it's got there the MOU and it's got due September. We did agree that that we weren't going to do this due to the transition to the Health New Zealand Māori Health Authority. There was really no point in renewing our MOU, that we would just extend to the end of this financial year.
Yeah.
If we could just remove that otherwise all that cross. Otherwise, it looks like we haven't done it.
Yeah, you got that?
Thank you.
Okay, are there any other observations on the work program? We're all comfortable? Vaughan has an observation.
The only observation I would pick up on is just the CE's performance review sits outside our closure of our term, and whether, in fairness for Kath, I know it's maybe seem a little bit redundant, but I'm not sure if that could be brought forward and have something meaningful to sign off the engagement. But otherwise, that's only something that I've just only noticed now.
I'll take, thanks for noting it. We'll work on it. Yeah, thank you. Anything else? Everybody else is comfortable? Okay, so we've got a resolution there. Just bear with. To note the work program, and we need a mover and a seconder. So Vaughan and Muriel, thank you. In favour, please say aye. Against, it's carried. Now, so that concludes that paper. We know when the next board meeting is, and we need a resolution to exclude the public. Just before we go into that resolution to exclude, I know we are an amount behind time, and we probably want to go on a break before we go into the next session, because the next session's got quite a lot of detail in it. So I'm probably going to suggest can I suggest that we just take another 10-minute break now? What is the time? Can I suggest we reconvene, just give me some thoughts, we'll see where this lands. We reconvene at 11:45. I'm wondering we may well have to push out the joint board to board at the other end. We need to give notice to people if that's what we're going to do. I just don't know how we're going to get all this done in time to have the appropriate engagement, have a break, and then be ready by 1 o'clock. So during this wee break now, I'm going to go and have some chats, see what we can nail down. Happy to have feedback from people, but let's agree we come back on at 11:45 to kick into part 2.